alaikum wa rahmatullahi wa barakatuh. Today's paper is going to be a case report done by Sans et al. In 2025. It is titled Guided Cavity Preparation to Access and Invagination Preserve Pulp Vitality of Immature Maxillary Lateral Incisor with Type 3A Dense Invaginatus with a 3-year follow-up. Dense invaginatus or dense dente is a developmental anomaly characterized by enfolding of the enamel organ into the dental papilla during tooth development. It has a prevalence of about 7%, particularly affecting the maxillary lateral incisor, usually unilaterally, in 5% of the cases, with type 1 being the most common variety. Pathologically, the invagination creates an enamel-lined voodoo canal that is often insufficient, posing risk of caries and pulp or preapical pathosis. Due to the close proximity of bacteria to the pulp, the Ohler classification system characterized dense invaginatus based on the degree of invagination and its relationship with the periodontal ligament, with type 3A being notable for extending below the cemental enamel junction and connecting laterally to the periodontal ligament through a pseudoforamen. For the patient's presentation, a 9-year-old male presented with a palatal sinus tract associated with immature maxillary left incisor tooth number 22. Clinical and radiographic examination identified type 3A dense invaginatus with a pseudoforamen and a peri-invagination periodontitis, but a healthy pulp. For the diagnosis imaging, a cone beam computed tomography scan was acquired to assess the anatomical variation and formulate a treatment plan. CBCT revealed a large buccolingual dimensions of the crown and root and invagination extending mesially to the midroot and a compressed main canal. The invagination communicated with the periodontal ligament via a well-defined bone defect, leading to a CBCT periapical index of score of 4D, indicating palatal cortical plate perforation. For the treatment plan, a guided endodontic approach was planned to preserve the pulp health. An intraoral digital impression and CBCT data were integrated to implant planning software to design a virtual drill path, selectively targeting the invagination while avoiding the root canal. For the procedure, the 3D printed guide was verified intraorally. A small round diamond burr was used to remove superficial enamel, creating reference point. The guided access to the invagination was performed with a 21 mm long and 0.75 mm diameter drill, advanced to a pre-planned depth controlled by the template and its physical desktop, ensuring minimal invasiveness and to avoid the root canal. For the chemomechanical disinfection, the invagination was disinfected using 2.5% sodium hypochlorite delivered via endovac, followed by 17% liquid EDTA and a final ethanol rinse. Irrigants were agitated with an ultrasonic tip. Patency and working length were confirmed with size 80K file, but no further mechanical shaping was performed. The invagination was filled with the pre-mixed bioceramic calcium silicate-based material during the same visit, and the access cavity was restored with resin composite. At 36 months, a 3-year follow-up, the patient remained asymptomatic with no pain or swelling. The tooth was not mobile and the palatal sinus tract had healed. Pulp health was confirmed by positive thermal and electric tests. And for the radiographic outcomes, radiographic assessment showed a progressive bony healing of the periapical lesion with no evidence of persistent pathosis. And for the root development was completed and a narrowing of the root canal width was observed, indicating preservation of the pulp health and continued root development. And thank you.